Okay, welcome to the Computer Science Seminar. It's my pleasure to introduce to you Dr. LePendu. I'm actually...
Paea.
Paea.
Just Paea.
Just Paea. Basically, he studied mathematics. He got his undergraduate degree from Whitman College, which is in Walla Walla, Washington. He went on to pursue and received his PhD in computer science from the University of Oregon, and then went on for a postdoctoral fellowship at Stanford, where he did a lot of wonderful work in data mining and natural language processing and mining knowledge from clinical data, where he worked with Stanford School of Medicine. And today he will be talking with you about the age of data-driven medicine, talking about some of the joint collaborations he's done with PCCI, which is the Parkland Center for Clinical Institute, where he is a senior, leading senior researcher for the data mining from clinical data, such as electronic health records, and also from doctor's notes. So I'll give you the floor. Thank you. Let's thank our speaker.
If I drift off and not loud enough in the back, Samir, can you raise your hand or something? Okay. Thank you, first of all, SMU, for having me. It's a great honor and a great privilege to be here. Thank you to Eric and Michael for the work that's led up to this collaboration we're trying to build between PCCI and SMU. And I'm very glad to see a full room. That's great. And thank you for being here. My main goal today is to kind of excite you and motivate you to care about healthcare data, to understand the problems that are worth solving in this space, and most importantly, to get a sense of the challenges that face us in working with healthcare data. I'm going to keep the talk fairly high level, but never fear for the computer geeks in here. There will be a little bit of stuff for everybody. I prefer discussion and questions, so at any time if you want to interrupt me, just feel free to do so. Raise your hand, say something, ask questions. I much prefer discussion than hearing the sound of my own voice. I currently work, like Eric said, at the Parkland Center for Clinical Innovation, PCCI. It's affiliated with the Parkland Health and Hospital System, or some of you know just as Parkland. It's the Dallas County Hospital System. I've been here for about 7 or 8 months. I stopped counting after 6. My job at PCCI is to advance the state of the art in the natural language processing technology. Does everybody know what natural language processing is? If you don't, raise your hand. I'll explain it. You don't know what it is? Okay. So it's the science or the technology behind understanding and making sense of or making use of free text, which are things that are written down in natural language, everyday English or Chinese or Japanese or whatever it is, and trying to make sense of it, use it for data mining, and so on and so forth. It's unstructured compared to, for example, a database or an Excel spreadsheet, for example, that is very structured. There are fields and columns. In natural language processing, there are no fields and columns. It's all just sentences. Since I've only been at PCCI for about 6 or 7 or 8 months, whatever that is, most of what I'm going to talk about today comes from my work at Stanford, which comprises the last 5 years or so of my life. I put this image on the screen to give you a sense of where that 5 years of work has led up to. It's something that is being called the Green Button Challenge. It's a challenge that we put out at Stanford to the rest of the world to say, we need to solve this problem, essentially. And let me give you a sense for what that problem is. Imagine, for example, a doctor is treating a patient. They're sitting in the room with the patient. In this case, it's a 55-year-old female, Vietnamese, who has an unusual presentation of asthma and some other complications, for example, hypertension, which is high blood pressure. The doctor is considering antihypertensive medication and is wondering, is there anything I should consider in this case that's unusual? Please warn me now before I give her this drug. The problem is a lot of times doctors will go to PubMed, which is the leading resource for publications in medicine, where there are a lot of case reports for cases that they can look up, try to answer these questions, but it cannot possibly publish and document every case that's out there. We don't write that many papers. We write a lot, but not that many. But chances are some doctor somewhere on the planet has seen a patient just like this one and asked the exact same question and proceeded with treatment, hopefully successfully. Wouldn't it be nice if the doctor could just look it up and say, what did that doctor do? So the question underlying this problem is, what has happened to patients like her? A very simple question, very hard to answer. If we could give the doctor, on their iPad or on the computer screen, instant results on if you did this or that or this other treatment, these are the likely outcomes that could happen. And the doctor can make a better and more informed decision for that patient that's sitting in front of them. Behind this question and behind the technology is a lot of problems that need to be solved. One of the most important ones, and I'll get into this toward later of the talk, is how do you find a patient just like her? Actually, I didn't even think about this, but Pedro Domingos is from your school, right? Before I get into the gist and the details of my work, I want to give two background slides to kind of lay the landscape of healthcare data and data mining in healthcare. So first of all, in 2010, this is kind of the political landscape. The Health IT Act and meaningful use kind of went into effect, and these big legislations have basically pushed forward electronic health record adoption. Why is it important? Let me tell you a story of where we were before this kind of thing has happened, right? Let's say a doctor at some hospital, Dr. A, wants to properly, and I say that in quotes because this is actually the proper protocol for electronically transferring health record data for a patient. So Dr. A wants to send, a patient's records to Dr. B at some other hospital. This is how it happens. Dr. A opens a medical record in their computer, prints it out, walks over to the printer, picks it up, walks over to the fax machine, picks up the telephone, calls Dr. B and says, I'm about to fax it, please go to the fax machine, hang up, fax it over. Dr. B walks over to their fax machine, should be standing there before it arrives. This is how we protect patient privacy, to make sure nobody else picks up that piece of paper. Dr. B picks it up, walks a few steps over to the Xerox machine, scans it, emails it to himself securely, and uploads it into the EHR with coffee stains, smudges, whatever happened in the meantime, uploaded along with it. Electronic transfer successfully complete. I'm not joking. This is in the training manual for how to protect patient privacy. So thanks to legislation like this, or big pushes to kind of get the data electronically recorded so that it's shareable and transferable electronically, digitally. In a few short years, I predict all of our electronic health records will be 100% digital. It's getting there very fast, thanks to the 2010 tipping point. In a few short years, we'll have found a way to both protect your privacy, but also find a way to make use of that data for everybody's greater good. So what I mean by that is, your electronic health record someday will save her life. Now, who doesn't want that to happen, obviously, right? I mean, we all want to protect our privacy, but we also want to help out everybody else. So the other kind of big background question that hopefully some of you are asking, like, why should the computer scientists in this room care about this problem? They've been doing data mining for years. They have all kinds of cool algorithms. What's so special about medicine? Well, I'll tell you that the data in medicine is kind of unique. It's different from most of the data that computer scientists have dealt with to date, and new algorithms are required. That's why we need your help. So this is kind of a visualization of IBM research that paints a picture for, again, a single patient over one episode. And there's green lines and orange lines and red lines, and these kind of visually depict the kinds of things that are going on for a single patient all at once. The idea behind this slide is basically, something bad happens, where the red occurs, it starts to spread and propagate through different kinds of symptoms or manifestations or other diseases, or bad drugs start getting injected. It just propagates and spreads, gets worse, doctor starts to intervene, and hopefully, thankfully in this case, things start to get better. The main point being that patients just don't have one disease at a time. They're not just taking one drug at a time. A multitude of complications and problems are happening all at once. They're constantly changing, and they're all interrelated. The other big point on this slide is this whole scenario is a little blip in the patient's lifetime. My advisor kind of puts this problem a very interesting way that I find. It's a little hard to wrap your brain around, but it's kind of a cool way to think about the problem. He says the electronic health record is like a flight data recorder that starts recording after the plane crashed. Think about that for a second. So that's it for the background, and I'm going to just jump into the data itself. So by the end of this section, there's two big sections in my talk. How do we get the data? How do we manipulate the data? How do we store that data? And what I call the patient feature matrix. So by the end of this section, you'll understand what this picture means. And the second half of my talk is once you build that, what can you do with it? So these are the two data sets that I've worked with the most so far. There's a Stanford data set, which is about 2 million patients, and it records data electronically from about 1994. And then there's the Parkland Health and Hospital System. Of course, they weren't recording it electronically since 1899, but they transcribe a lot of this data, they enter it, they backfill the data essentially to the database, the Parkland. They're not that far apart in terms of the population size and the data size itself. 25 million notes, clinical notes, doctor's notes, text, versus 65 million. That's kind of on the same order of magnitude, at least in my book. What this little picture here shows is that, though it goes back to 1992, 1994-ish, not all data is gathered in the same way. So this is medical notes, Social Security data, lab tests, pharmacy orders. But you can tell around 2010, when this big push for go electronic has happened, it all starts to get filled up kind of across the board. Same thing with almost every hospital system in the United States right now, that they're all coming online digitally. I'm going to focus on clinical notes because that's what I like, that's what I think is challenging, that's where I think the real science needs to happen. But again, there are big databases that store not just the clinical notes, they also store lab data, which is highly structured. Urinalysis, for example, medications, the drugs that people are taking, that's all structured. Their diagnoses is a really important part of the medical record. When you go get diagnosed for a heart attack, for example, there's a code for that. They enter it into the system. Unfortunately, in the United States, compared to most other countries, that code represents not that the person had a heart attack, but that they're getting an insurance bill back for treating for a heart attack. So these codes are focusing on the billing and insurance reimbursement problem. They're good surrogates for understanding what's happening to the patient, but they're not perfect. And of course, we have death information, if people die. That's important if you want to prevent deaths. Is everybody following so far? Okay. This is what a doctor's note looks like. So I'm not talking about handwriting. I don't do that kind of NLP, although that's an important thing to be solved too. But we assume, first of all, that the data is entered. Oftentimes it's transcribed. Somebody else types it in for the doctor. The doctor's not typing this into the computer. A lot of times they dictate it, and then somebody else types it in. But this is what it kind of looks like. I'm going to push the go button. Just kind of give you a flavor for, they're kind of long. There's kind of these sections. It's semi-structured. There's lots of abbreviations and weird numbers and things like this. It's not like natural language that we think of. They're not sentences. Most of the time, they're kind of short and sweet phrases. If you throw the Stanford parser, NLP parser, I should probably explain what that is. The Stanford parser is a parser that can deconstruct sentences in English really, really well. So you can add any sentence you want and it say, that's the noun, that's the verb, that's the object. You can't take that parser and apply it to this text, it won't work. And the main reason behind that is all kind of centered around patient privacy. They're not going to take these this is a de-identified note, so there's no identifying information, by the way. I'm not revealing anybody's secrets here. But a lot of this data will actually have a person's name in here, their birth date, and all this personal information. And you're not going to put that online for the whole world to build parsers on. The way Stanford's parser is built is they literally have a giant corpus of English language that they can mark up, share publicly, and everybody goes at it to build the best parser they can. And that's how the Stanford parser and several others evolved. No such thing exists in clinical text, because there's no such corpus out there on the internet for everybody to use. So in a sense, clinical NLP is way behind the curve in terms of NLP that's being used out there in Google, for example. So what else can we do if we don't have these fancy parsers to help us out? What's happening a lot in medicine is we can very simply extract clinical concepts from the text, medical concepts. For example, atrial fibrillation is, obviously a medical phrase. We know what those phrases are, and we can easily just search through the text for those. So what we're looking at here is on the left-hand side is a snippet of one of these notes, the past medical history section, a little paragraph. In the middle is, an indexing mechanism. It's like an inverted index, the kind of thing Google uses for search. That records exactly where that happened in the note in a very efficient way. And on the right-hand side is if we had indexed this entire note and tried to reconstruct it from the index alone, what would we get? On the right-hand side, it looks almost identical to the left-hand side because the indexing mechanism is pretty rich. It understands medical concepts and phrases well enough that it can capture almost the entire richness of the text. That's the point of this slide. There are words that are not in your typical English dictionary, for example. Medical language is full of jargon. And like I said, it's very long. There are 3 more points I want to make about this before I move on. The stuff in red on the right-hand side, like hypertension and autoimmune and so on like that, they're in red because they're unique. And this is a special thing that happens in medical text that's different from regular English. The purpose of all these doctor notes is to kind of record what's happening to the patient so they can make accurate diagnoses and then treat the patient. Diagnosis is the process of elimination. They don't always know exactly what you have just when they have a hypothesis, and they start to rule them out. So medical text, 40% of it is negated information. They don't have this, they don't have that, they don't have this other thing. If you want to mine this data, you have to be very careful to separate what they do have and what they don't have. So what we call the negation context is extremely important in medicine. There are 5 of these contexts. Another one of them is family history. So you notice all the medical stuff in the family history section is in red, because that's called the experiencer context. Right? It's not happening to that patient, it's happening to somebody else, their family. So that's the second thing. What was the first thing? It's full of jargon. I covered that. Synonyms. It's not just enough to recognize a medical term, because there are 18 different ways, at least, to say heart attack. There's heart attack and myocardial infarction. A lot of times people think they can do string similarity. Those things are not string similar. They're not even spelled anywhere near the same. So, but there are ways to recognize that heart attack and myocardial infarction are the same thing. They're synonymous. And I'll explain that a little later in the text. It's important to do that so you can normalize the data when you extract that information. This patient has heart attack. Oh, that patient has myocardial infarction. Well, they have the same thing. The third and final thing is it has to be very fast, because we're talking 65 million notes. And I'm going to give you a little kind of example of why that's important. The best clinical concept extractors out there are MetaMap, CTEX, and Medley. MetaMap would take 2 minutes to process this note. Okay? Let's say you were great and you could blow it out of the water and process this note in a second. You'd be like, awesome, right? Okay, so let me try to do the math here. If you could process a clinical note in a second, how long would it take to process 65 million of them? Well, I can tell you that it would take 12 days to do 1 million notes, which is not too bad, right? You waited a couple weeks, it's done. 65 million would take you 2 years to process. So literally, if you wanted to start a research project on Parkland's data, you would launch your NLP tools and go on a 2-year vacation before you could do anything. So at Stanford, we worked really hard to make this process really fast, and we can do it under a millisecond now, which means you can process the entire Parkland data set overnight while you're asleep. That completely changes the game, by the way. Don't know if you got how important that is, but it is. Okay, I'm talking a lot. Some of you, can't be away from your iPhone for 10 seconds and want to keep your thumbs busy, go ahead and give it a try. I won't be offended. Oh, you want to write that down? Demo.lexigram.io. This is a product that is being spun off from the Stanford tools we built. So how does this relate to the patient feature matrix? What that tool does is, like I showed you before, it extracts the medical concepts. So you start with a note. In this case, it's just one sentence. It's a small, tiny little note. You throw it over to something like Lexigram that's really fast. It tags the note. It highlights the medical terms of interest. You can think of it as a list. It understands the context. This potassium is in yellow because it's in the hypothetical context. They may have a potassium problem. We're not sure yet. These are what we call features that you can extract from the text. For those of you that think in terms of data like in Excel or spreadsheets or CSV files or tab delimited files, flip this sideways. What this data means is every record, every note is one record, one line in your Excel spreadsheet, one row. Each of these features is a column. Now multiply that by 150,000. There are 150,000 different features we want to look at. Here there are 7. So in your spreadsheet, you would have one row for this note and 7 yeses and 149,993 no's. Okay, so it's a really long row. Let's call this one the note feature vector. A vector is just kind of a list. So what does the matrix turn into? Okay, great. So one patient doesn't just have one note, right? One patient hops around the hospital multiple times, meets 3 different doctors, 5 different nurses. All of them are taking notes. And they go to the hospital on one day. 3 years later, they come back. 3 years later, they come back. Hopefully every 6 months, they're coming back. So you take this record and you throw it across time. So that's what this kind of depicts. Take your note vector. You have many of them for one patient over time, 20 years roughly, depending on your data set. And of course, we have about 3 million patients, so your matrix is a cube at this point. It has the feature dimension, time dimension, and there are 3 million patients. We started off with notes, 65 million. I don't know how big exactly that is. I would guesstimate about 100 gigabytes, about the size of your music library and your laptop. Doesn't seem like big data, but when you project it into something like this, you have big problems to be careful of. I mean, this is really big. Luckily, like I said, there are 149,993 no's, which means it's extremely sparse. You don't have to record all the no's. So ultimately, the punchline is your index of all these clinical terms, you can store pretty efficiently on roughly about 20 to 50 gigabytes of space. Not quite on a USB stick, but almost. A couple more years. Everybody following so far? I haven't lost anyone? Okay, good. The last point I want to make is this 150,000 features. What are they and why are there so many? Medical knowledge is extremely complex. Things can be very, very specific. The jargon can be very specific. And things are very interrelated. So what we do is not only tag these things, but we manipulate them in ways, for example, like saying heart attack and myocardial infarction are the same thing. If the Vietnamese patient, for example, is taking an antihypertensive like lisinopril, chances are we know she's taking lisinopril, it's because she has hypertension. Those things are related. They're not independent. The nice thing is we know a lot of these interdependencies based on medical ontologies. An ontology is a graph, like structure, that records all these relationships. We know, it's written down electronically, that lisinopril and hypertension have a special relationship called the may-treat relationship. We can navigate these graphs to help make better use of these 150,000 features. With a simple little trick, for example, you can take those 150,000 features and aggregate them down to about 2,000 with like a push of a button. I'm going to skip going to the methods because I want to kind of go into the the, why do we do all this problem, but if you're curious about ontologies or the matrix itself, actually, why don't we pause here for a second? Nobody's asked a question yet, so why don't we open it up for questions?
So you say that you have 150,000 features, right? And you said that some keywords are related and some are identical. So is that those words, it's actually one feature that you're talking about, like inside 150 features?
They're different.
Okay.
So heart attack would be a feature, myocardial infarction would be a feature. If you were smart about using your graphs correctly, you would say they're the same and you could eliminate the duplication.
Right.
They're not just synonymy relationships, they're hierarchical relationships. So like I mentioned before, antihypertensives, there's like 6 or 7 of these drugs. You could literally take, if a patient's taking lisinopril, you can compare them with a patient taking a different hypertensive, use the graph, and normalize that together. So you can analyze them in multiple ways to aggregate, project, transform, and so on. Good question. So, congratulations, you now have a giant Rubik's Cube. So what do you do with it? There's lots of different use cases that we've worked on. I may not get through them all. How much time do we have? I don't see a clock. It's 2:30, about 20 minutes? Okay. I'll try to get through as much as I can. I will hope you can ask questions along the way. This is hopefully the fun part. The first one is where I spent most of my early days at Stanford working on. It's called pharmacovigilance. Pharmacovigilance is a science of drug safety. How to detect and prevent adverse side effects to taking a drug. In 2005, for the older folks in the audience at least, you probably heard of Vioxx. Big scandal, big drug, killed a lot of people, was recalled from the market after 5 years of being on the market. One of the bigger lawsuits, or I think it was Merck, if I remember right, $6 billion. So the question is, if we had our giant Rubik's Cube before 2005, could we have prevented this big disaster? Yes, we could have. So Vioxx is a drug for treating rheumatoid arthritis. You probably know what that is. It's kind of these swelling in your joints. It's very painful and uncomfortable. So you take Vioxx to kind of alleviate the pain and swelling and treat the symptoms. So this is basically the gist behind the algorithm for detecting Vioxx early. So start off with your giant Rubik's Cube. And the first thing you do is you scan it. You search through it very rapidly because it's already indexed. For everybody who has rheumatoid arthritis, out of 2 million patients, you now got down to 20,000. Throw the other however million away. Can't count that fast. Okay, so you want to look at 3 things of interest. People who have rheumatoid arthritis, first of all. That becomes your cohort to study. You need to know people who have MI, which is myocardial infarction or heart attacks. And of course, the people who take Vioxx. Some of them take it, some of them don't. There are 3 or 4 different drugs for treating rheumatoid arthritis. So from the people who are taking rheumatoid arthritis, you literally tag all of those, or search again your index. Those who have MI and those who don't. Those who took Vioxx, those who didn't. And you literally just throw them onto a timeline and start counting. This is the case, the bad case, where they have rheumatoid arthritis, so they took the drug, and then they got a heart attack. If it happens within a narrow enough window, you know that that could be a case where something bad is happening. You put it in your bucket. Most of the other stuff is noise. It's not a causal relationship. It's not likely to be a causal relationship, I should say. And the rest is just calculating an odds ratio, which is a simple, add and divide strategy. You just count them all up, and you start putting them into 4 different buckets, and you just divide. It's very simple math. I won't go into it. The gist of this slide, though, however, is if you didn't use the text, at Stanford's data, about 2 million patients, back in 1999, it would be about 1 million patients, you wouldn't see the signal. This is using the coded data, the billing codes, right? The billing code for heart attack, the billing code for rheumatoid arthritis, and the medication data only. You would not have seen the signal. You would not have said, oh, call the FDA, this is a bad drug. If you throw the text into your giant Rubik's Cube, the signal screams loud and clear. These numbers basically say you have a 200% increased odds, 2 times more likely to get a heart attack if you take Vioxx. And this would have been detected just using Stanford's data 2 years before the FDA recalled it. This would have been a moment where we literally pick up the phone, call the FDA, and say, stop this drug.
With this method, you kind of have to know what you're looking for on the onset. So if you were going to use this as something kind of scalable and sustainable, would you be searching and kind of mining this data for key relationships every so often or periodically?
Good, very good question. I'll answer that in 2 seconds, or 5 seconds. So there was a study that said if, Stanford only had about 1 million or so patients, so the point being that with just the 1 million, you could have detected the signal about 2.5 years into the problem. If we had the entire United States data, 300 million patients worth, we would have recalled the drug within 3 months. We just didn't have these methods. That's the problem. So to answer your question, so what if you don't know what you're looking for, right? Well, I can tell you there's about 2,000 to 4,000 drugs, depending on how you count them, the aggregation thing. And there's about 28 events that we routinely monitor for, or the FDA routinely monitors for. Do them all. That's what we did at Stanford. We computed all permutations of this. Not that hard. Takes a couple hours on the Rubik's Cube matrix. And I literally had about 28,000 of these little PDF files on my laptop at one point. And we're trying to study where are the signals. It's dangerous to do this because you can over-hypothesize, obviously. But for the 9 out of the 10 recall, for 9 of the recalls in the past decade that the FDA has issued, 6 of them you can detect at least, on average, about 2 to 3 years in advance, just from Stanford's data. For some of them, like this one, Cerevastatin, it's a statin drug, kind of like usually taken for cholesterol, for example. You're looking for the event rhabdomyolysis, which is really horrible, but it's extremely rare. So in Stanford's, on the right-hand side, what you see here is only 100 patients at the time had it. You're not going to see a signal. It's not enough data. But if you had this on a national scale, all of these things would have just popped right up. The problem is you're going on a fishing expedition, and sometimes you'll see signals that aren't really there. So you have to be very careful to do what's called a hypothesis correction. Another kind of cool application area that I kind of started working on is called off-label drug use. It's the opposite problem of looking for a drug and then a side effect. If you think of a side effect as a medical condition, off-label drug use is looking for the indication for a drug. So they have rheumatoid arthritis, that's the indication for Vioxx. What happens is doctors routinely, they use their best judgment. They're allowed to do this, it's perfectly legal, nothing wrong with it, to use a drug to treat anything that they feel deemed is necessary to improve the patient's health. So a lot of times they'll take a drug, but using their collective knowledge and understanding of biochemistry and so on, saying, oh, I can use this drug to treat this other thing. Does that make sense? And so they're basically not reading the label and saying, oh, please use this drug only to treat this, that, and the other thing. They're using it to treat things that are not on the label. That's what off-label drug use means. A lot of times this works great. For example, there's a drug, Avastin, that's used to treat cancer. Because of the biomolecular mechanisms behind the drug, it works really well to treat macular degeneration. It's used all the time for this. And it's a well-known, well-established, highly effective treatment, off-label. Vioxx, Viagra, everybody knows that drug. I don't know if you know, but it was developed for something completely other than what it is used for today. In fact, what it is used for today was one of the bad side effects of using Viagra. So now it's its main indication. Now it's on the label. The problem is 21% of the ambulatory means kind of ER, out of the hospital environment, but through clinics and so on, are using drugs off-label. But most of the time, we don't really know whether it's actually working. It's not documented that it is, and we don't know how safe it is. This is one of the problems you can solve by analyzing this giant matrix. You can basically, from this matrix, document all possible off-label uses and study their efficacy and safety. Comparative effectiveness is basically comparing two drugs against each other, for example. Which one's safer? Which one's more risky? Which one works better? This is kind of a more interesting case than just comparing whether one drug is better than the other. Peripheral artery disease, PAD, is, oops, it's auto-advancing, is what I think of as a layman is a heart attack in your leg. It's really bad and it's really painful. And it's hard to walk if you have this disease. So there was a drug called Mironone that was used to treat it, but they discovered that it had really extremely seriously harmful side effects. So they took it off the market. Because of some biological similarities, or biochemical similarities, they black boxed Celestazol because it was biochemically similar to Milrinone. It was the only viable treatment for peripheral artery disease on the market. A black box warning doesn't say don't use it. It says be very careful when you use this drug. So a lot of doctors, are very cautious and they won't prescribe it. Some doctors think this is complete nonsense. This is guilt by association. Just because there's a biological similarity, drugs work in sometimes mysterious ways. They don't just have one or two targets, but the way they work is sometimes very poorly understood biochemically. So just because they have one similar biomolecular similarity, it doesn't mean it's going to have the same side effects. So, the question, of course, is Celestazol effective, first of all? And does it really have the side effects that Mironone has? And because some doctors are using it in practice, you can study the practice, what we call practice-based evidence, what they're actually doing and how the treatments and outcomes actually occur. And you can convince yourself pretty easily it doesn't work the same way. And this black box warning is probably causing harm because people aren't using it as the best effective treatment for peripheral artery disease. The interesting thing and why this is important is because of this black box warning, you cannot do a clinical trial on this drug. Because you have to, first of all, prove the benefits outweigh the risks. So by doing this study, now we have made a case for, look, it looks like the risks aren't as bad as we thought. Let's do a clinical trial and prove that this drug is actually a good one to prescribe. So this will probably be my last one because it's my most favorite one, is what we refer to as the phenotyping problem. It's a little hard to describe because it kind of sounds like genetics, but it isn't. A lot of times we don't really know how to describe the patient we're seeing in front of us. A lot of times if you sit a doctor in front of it, or in fact, this is kind of the inside joke at Stanford, is you put one patient in front of 3 doctors, you get 3 completely different diagnoses. Or 3 different opinions, or however you want to put it. So what we want to do is from the data, describe what I'm seeing in this patient. There are different ways you can kind of think about this problem, and I kind of laid them out in 3 different ways. The first one is there a signature for pancreatitis? So if I took that signature and put it on any patient, I could scan them, right, and say, you have it, you don't have it. Is there such a signature? And I put the facial recognition kind of image there because it's kind of the same problem. Telling one face from another is like telling one disease from another. The second kind of illustration or case is what we do at PCCI regularly. We call it disease ID. How many of you know what Shazam is? Can you explain to the rest of the audience what that is? Yeah.
You can just find the song by just turn it on, and directly you can find the name of the song of the singer.
Did you hear that? So Shazam is an app you can download on your iPhone or your Android or whatever it is you have. And if there's a song playing in the background, you can literally turn it on and make it listen, and it'll tell you what song it is. So the question, does this patient have congestive heart failure? We want to know this all the time for a lot of patients. It's an important disease to track in the hospital system. Is Shazam for disease? And finally, kind of bringing the story back home to the green button challenge, I want to find patients like her. right? And how many know what Pandora is? Most people don't know what that is. So Pandora, you can upload your favorite artist, you can type in your favorite song, and it will build a playlist of similar songs. That's exactly what we're doing here. I have a certain patient, here's the patient, build me a playlist or a cohort, it's called a cohort, of similar patients. And from there, you can study the disease in depth if you have a lot of them. I think that's where I'll end today. Thank you so much for having me. Are there any questions? Again.
So according to the last slides, you said you maybe listen to some sort of voice, right? So is it listen to patient description or listen to like a heartbeat or what kind of, recognize of that system?
It's a good question. It depends a lot on the data, right? So for the clinical notes, we have a product for detecting sepsis, for example, at PCCI. What this product does is it listens, which means, in my mind, scanning the data that's streaming in through the hospital system. It looks at lab values. If you're hooked up to a heart monitor, it'll read those signals. It reads all the data that's streaming through the hospital system about a patient. Usually for sepsis, that patient is literally lying in the bed, being monitored constantly because something really bad happened. They just came out of a major surgery, for example, or something like that. Sepsis, if I didn't explain it, is a disease where you get a bacterial infection in your blood and it's fatal if you don't treat it within 24 hours. So this product is really important that you study all the data that's coming in and rapidly make a decision within, minutes or hours. Treat this person with antibiotics immediately or escalate, right? It sounds like an easy thing. Why don't we just have a doctor sitting there monitoring? Well, there are 100 people in a hospital and 3 doctors. They can't monitor all of them all at the same time. So that's why we have the computer monitoring all the data as it's streaming to detect it as early as possible so they can intervene. So in that case, it's listening literally to your heartbeat. For the other ones, for congestive heart failure, for example, it's not such a time-critical problem to solve, so you can listen, which means read the notes to detect that. Notes aren't time-critical, right? Because you have to, talk to the patient, you go back to your office and you write them down. There's minutes or sometimes hours that span between the actual conversation and the actual recording of the note. You don't want to study notes to solve sepsis. You're going to be in big trouble.
All right, thank you.
Good question. How about in the back? A question?
I wonder, is there any argument for why you might not want to do something like this, where essentially kind of displaying different diagnoses to a doctor because of the argument that it might bias them in the wrong direction or take them away from a diagnosis they may have actually gone with, which may have been in the right path. Is there any, do you have any kind of pushback
Yes.
from that argument? Oh, really?
That's a very valid argument.
Yeah.
So, let's take this this green button kind of, futuristic kind of idea of where we want to go and think it through, right? Let's say we had the system in place and we were using it for years. What will happen is we'll start training doctors to only do certain treatments. It's kind of the same idea. They may not be the best treatments. They might be the average treatment, for example. The average best treatment. This could mask other potentially good treatments. It's a danger, but it's also something worth doing anyway. It's a trade-off. You always want to kind of, in a lot of AI algorithms, it's called hill climbing, right? You want to jump and make sure you don't find some local optimal. You want to make sure that you can kind of step back for a second and say, wait, maybe we're missing something. Maybe there's another way. And you can always throw that kind of randomization into these kind of algorithms. Good question.
I have another question. This is my last one.
Go for it. Don't
So
be shy.
I kind of maybe am lost in the early of the few slides that you're talking about natural language processing, right? My understanding is the same word has different meanings, right? Depends on the context. And you said that for this script, medical note, we cannot just using normal English grammar to extract token and so on. So in this case, what did you do for it? Based on any kind of grammatical something, or what you learn from your large data to become a brand person?
Let me try it again at that. It's a big problem to solve, but related to that is a problem of ambiguity, right? Peripheral artery disease, I talked about that. The abbreviation for it is PAD. Diaper pad is spelled PAD. You can easily confuse these words if you're not careful. So you can combine different methods for disambiguating. One of them is what I call the ontology-based approach, where you can use the knowledge in these knowledge bases to understand, peripheral artery disease is a disease. Its abbreviation is PAD. It's a concept. It has several synonyms, including PAD. Peripheral artery disease is also a synonym. These are the same. In some cases, not always, because sometimes it refers to a diaper pad. But there are relationships also in these ontologies for psilocybin. So you can combine all of this information to help disambiguate which case is going on in this note. So, stepping back a little bit, we have ways using the ontology to group synonyms together based on the concept they represent. So one concept, 18 different synonyms. These are all the same. Some of these synonyms overlap with other concepts. So that's where you get two different concepts, the diaper pad versus the disease. And you have to kind of tell which one of these concepts is actually the case. If you scan ahead or behind using the context of the note, you see the word psilocybin nearby, you know from the ontology, psilocybin is a drug for treating peripheral artery disease. It's probably not talking about a diaper pad. You can cross it out. That's kind of the gist. So you use the context to your advantage. Does it make sense?
Yeah, that's definitely making sense. Yeah.
It's really hard, but that's what you do.
We have time for maybe one more question.
So you said you were able to get the time to read a note down to a millisecond, and that to do all of Parkland's data, it would run overnight. Well, if you have all of the hospitals on the same system, don't you run into that problem of it taking a long time, even if it's a millisecond? So two-part question, how did you get it down to a millisecond? And then two, how do you solve the problem with the bigger pot of data? Do you throw more computers at it, or are there other ways to address the problem?
Okay, good question. How do we get it down to a millisecond? So first of all, a lot of these other attempts at extracting medical concepts try to run parsers. Parsers are intrinsically slow. They try to understand a sentence, break it down into these pieces. That's what's slowing them down. We flipped it on its head and said, we already know what we're looking for. We don't need to know that that's a noun phrase. Heart attack is a noun. We don't care if it happens in a verb context. Don't bother parsing the sentence. So we literally take all of the knowledge we can find all of the synonyms we can find up front, right? We build one giant dictionary. So think of it as one giant control F, right? With a giant list behind it, about 3 million concept terms behind this dictionary. And we just look it up. So that's what speeds it up. It's a giant lookup. Instead of trying to parse and break down this sentence, that's what slows these parsers down. The other question is, yeah, we throw more machines. So the millisecond, the processing overnight, what I meant by that is you could literally do it on your laptop. You don't need a supercomputer to do this. On your laptop, you could process all of Parkland's data overnight. So every patient is independent, right? You don't need to think about, it's a, what's it called? Naively parallelizable. There's a yeah, embarrassingly parallel problem. You can literally take 65 million patients. If you had 65 million computers, like Google, you could do one patient on one computer and you'd be done in a millisecond. So at Stanford, we literally ran this on one computer. At Mayo Clinic, for example, they use one of these programs that's kind of slow, and they literally have a giant cluster. They literally wait the whole year, and they have about 50 million patients worth of data. It's bigger than ours, but we're trying to work with them to say, well, that's too long. Stop doing the parsing.
Is that the biggest bottleneck? Is the extraction phase where you're actually going in and
In terms of the computation, yes. Yes. But in terms of the bottleneck, in terms of real progress, no. The real bottleneck is the privacy concern. The big thing that people want is access to the data, and it's really hard to get access to patient data for good reason. We don't want to put, like credit card information is getting stolen today. We don't want patient records getting stolen, but there has to be a middle ground that we can find, where we can somehow anonymously share this data, make good use of it, and still keep people's private information private. That's the bottleneck. But like I said, in 5 years, I think that will disappear.
Interesting. Well, I know that some students do have class that kind of butt up against this, so let's thank our speaker one last time. Thank you.
Thank you.